discussions and sharing. So we hope to have same here this session also. In this session, we have 3 articles lined up for discussion, which are handpicked by our eminent moderators for today, who actually needs no detailed introduction. Dr. J.K. Mahajan from PGI Chandigarh and Dr. Pradnya Bendre from Wadia Children's Hospital, Mumbai. So before I hand over the proceeding to them, I would like to invite our Editor-in-Chief, Dr. Asik Shah, for his introductory comments for today's session.
Thank you, Manoj, for starting the session. As many of you know that the number of submission and publication is increasing over last few years. The journal is doing well. I thank all the reviewers, authors, and editorial team members for working and making this process as quick and as smooth as possible. We have been able to decrease the turnaround time, and at the same time, the quality of submission and paper publication is improving steadily. All this is ultimately going to result in improving our impact factor. Idea of this particular Abhigyan, JIAPS Abhigyan, is to popularize JIAPS, or whatever paper submitted and published in JIAPS, that IAPS members and others from globe read the article. If they read the article, it will ultimately materialize in improving the impact factor. With all this concept, we have started this Abhigyan. Now, the interesting part of this is most of the papers which are presented will be presented by junior colleagues, and the moderators are relatively seniors, and the audience is going to be the mix. So it is the interesting overall presence, and it definitely going to help us in improving overall the content as well as popularizing our journal. With these words, I will hand it back over to Manoj to take it further. Manoj, please.
Thank you, sir. Thank you, sir. So for today's presentation, 3 articles are lined up. Would hand over the proceedings to both of the moderators. To start with the first presentation by Dr. Priyanka Mehdi. Dr. J.K. Mahajan, sir. Dr. Pradnya Bendre, please take over. Welcome, sir. Welcome, madam.
Thank you, Dr. Manoj. So, Dr. Bendre, can we invite the first presenter? Dr. Mehdi, please share your screen and start your presentation, please.
Good evening, everyone. Greetings from CMC Vellore. I'm Dr. Priyanka. I'm a pediatrician, and we had done this survey study on management of thoracic empyema in children in collaboration with the Pediatric Surgery Department of our institution, today represented by Dr. Arun Kumar, who is Associate Professor and also the corresponding author of this paper. So let's see what we did. As we know, thoracic empyema has a huge burden in India. Incidence of pneumonia in India is estimated to be at 0.28 episodes per child per year, and about 1 to 3% of this is complicated by pleural infections. So in 2022, the IAP came up with the standard treatment guidelines, but this is a consensus statement and not evidence-based. There are also real-life issues which can actually differ from implementation of these guidelines. And these are basically the diverse presentation of thoracic empyema per se. Also, a child with thoracic empyema might present to various specialists. Different there is a range of healthcare setting in the country, and the population is vast and varied. Not to mention that there's also a gap in the knowledge about management. So there's no accepted gold standard management universally present for thoracic empyema. And that is what led us to to do this study, to shed light on the real world implementation of the IAP recommendations for thoracic empyema. And our objective was to assess the extent of variability in clinical practice employed for managing pediatric empyema across various centers. So how did we do the study? We formulated a questionnaire of about 12 questions based on previous questionnaires on the same topic done across the world. And we circulated a Google form through various platforms like WhatsApp, Telegram, and personal emails to various pediatricians, pediatric surgeons, pulmonologists, and intensivists. This was done over a period of a month, and after that, we collected the data and started the analysis of results. So let's move on to our results. The survey was answered by about 252 healthcare professionals, and the first 4 questions was based on the demographics. As you can see here, there were about 51% of the healthcare professionals answering our survey were pediatricians, 37% were pediatric surgeons, and the experience, if you see, it's divided equally across various age groups. Most of them worked in academic institutions, and about 17% responded that they see about 20 cases of empyema per year. The remaining 8 questions were based on management of intervention and management of empyema, and we'll look at it in more details in the subsequent slides. So the first question was based on the choice of imaging. When a child presents with empyema, what is the choice of imaging, and what is the role of CT thorax in such a child? We will now look at the response that we got through this survey and also compare with the standard guidelines which are available from ATS, the NHS, and IAP. So regarding imaging, when a child presents with empyema, the IAP doesn't clearly mention about the order of priority, but it describes the utility of both X-rays as well as CT scans. When it comes to the ATS, it says that the pleural ultrasound should be performed routinely in addition to conventional X-ray, and CT of the chest should be obtained when pleural space infection is suspected. The NHS says that chest X-ray should be done, and ultrasound if a significant or a symptomatic pleural effusion is seen on X-ray, a timely ultrasound should be arranged. CT scan is not indicated according to the NHS guidelines unless a surgery is planned. In our study, most pediatricians and pediatric surgeons, as well as intensivists and pulmonologists, preferred ultrasound, and a few of them chose CT scan for all cases, but in majority of these groups, they preferred only when it is indicated. Let's look at the next question. The next question was about the role of thoracocentesis, whether it can be used for diagnostic purpose or for both diagnosis as well as evacuation of fluid. The IAP states that we can use it for diagnostic purpose as well as for evacuation of pleural fluid, and similar statement can also be seen in the ATS guideline as well as the NHS guideline. Our finding in our study was also that most of the pediatricians, the surgeons, as well as intensivists and pulmonologists preferred chest drain placement as the initial intervention. Let's look at the next question. This was about placement of the chest drain. Where exactly to do it? So the options which we provided were either ward with no sedation or light sedation, or theater with light sedation and general anesthesia. So as you can see, the IAP and the ATS actually do not describe this, but the NHS says that the drains are to be placed under general anesthesia. In our setup, most of the practicing clinicians preferred to do the ICD insertion in ward. About insertion of percutaneous chest drain, whether blind or under guidance is preferred. As you can see, IAP suggests that ultrasound guidance is ideal, ATS also recommends that diagnostic thoracocentesis should be performed with ultrasound guidance, and image guidance pleural drain placement is also recommended for therapeutic management. The NHS doesn't comment on this. In our study, we found that 24% pediatricians, 18% pediatric surgeons, and 61% of intensivists or pulmonologists would prefer using image guidance for chest drain placement. Who inserts a chest drain? That was another question in our study. Here in IAP and ATS guideline, it doesn't really mention who should do it. In NHS guideline, it's clearly mentioned that the pediatric surgeon has to be called for this. And in our study, we found that 26% of pediatricians and 30% of intensivists would refer the child to a pediatric surgeon. About use of fibrinolytics, the IAP states that it is indicated when there are loculations or septations on the ultrasound, even early in the course of empyema. It's absolutely contraindicated when there's a bronchopleural fistula and bleeding diathesis. The ATS tells us that intrapleural fibrinolytics should not be routinely used for complicated pleural effusions and early empyemas. The NHS says that intrapleural fibrinolysis is required when loculations and frank pus are present. Our finding was that 60% of pediatricians and intensivists prefer fibrinolytics in all loculated effusions compared to only 38% of pediatric surgeons. We also asked about use of trial of fibrinolytic agents before VATS for loculated effusions. IAP states that it's equivocal for both VATS and fibrinolytics. Centers with minimally invasive surgical expertise should go for VATS. It's a better option. And centers which lack minimally invasive surgical expertise can go for fibrinolytics. ATS and NHS doesn't comment on this. And in our study, 75% of pediatricians and 84% of intensivists as well as pulmonologists prefer the trial of fibrinolytics compared to only 50% of surgeons. We asked about indication for VATS. When would they refer a child for VATS? And in if you look at the IAP guidelines, it says that stage 3 empyema, definitely. Stage 2 empyema, if sepsis is not controlled and if there's clinical deterioration, then the child should be referred. ATS says that it should be done in stage 2 acute empyemas. NHS says that only when there's a worsening clinical status, VATS should be considered. Our finding of our study, 50 to 60% practicing physicians felt that when there's a clinical need, the child should be referred for VATS. For stage 2, 45% surgeons were in favor of a VATS. For stage 3, 5% surgeons, and pediatricians, intensivists, and pulmonologists were equally divided between both categories. So there was a recent network meta-analysis which incorporated data from 11 trials involving about 590 patients. And length of stay, they found that the length of stay extended with chest drain with or without fibrinolytics. However, the cost advantage was seen with fibrinolytics, and the complications and reintervention rates were similar. So our study, basically what we found was when it comes to imaging for a thoracic empyema, there's a consensus present between physicians as well as surgeons, and it's in line with the recommendation. When it comes to thoracocentesis, consensus is present on when to insert the chest guide, image guidance, while recommended is insisted only by intensivist. Fibrinolytics, there is no consensus, and there's probably over-reliance among physicians and under-uses by surgeons. About VATS, there's again no consensus. It's preferred only in later stages or in worsening clinical status by physicians, and surgeons prefer VATS even for stage 2 and early empyema. So just moving on to discussion. Access to fibrinolytics and facilities for performing VATS will also affect the real-time practice, but this was not really seen in our study. The results are indicative of a parallel medical and surgical protocols for the same underlying problem. So we feel that a multicentric prospective study will help in development of evidence-based protocol to optimize the management of thoracic empyema in the Indian population. These are our references. Thank you.
Thank you, Dr. Priyanka, for your very nice presentation. This is very good paper on important subject of empyema, regarding which many physicians and surgeons will not agree on many points. Timeline of presentation is an important aspect. So was it part of your questionnaire or not? Like paranemonic effusion turning into empyema, how many days after pneumonia and paranemonic infusion the patients are being seen by physicians and surgeons in your survey? Like 7 days, more than 7 days, more than a couple of weeks? Was it like part of your questionnaire?
We did not include that actually in the questionnaire.
One more question about your questionnaire. I just wanted to know whether your questionnaire was validated. And second, rather, is comment is the questionnaire should have mentioned whether the expertise and facilities of VATS are available, because that will definitely change the answer of majority of the pediatricians as well as pediatric surgeons.
Yes, ma'am. So validated the questionnaire, and like you mentioned, it was mentioned in the questionnaire. The link is provided in the slide actually. It was mentioned in the questionnaire.
So that is linked to the people given, but before sending the link to the population, have you validated the questionnaire? Have you double checked the questionnaire by distributing it to the few people, taking the feedback, and then changing the your questionnaire again? That would make it better questionnaire.
Ma'am, that was not done.
Okay. So participants can put their questions in the chat box. So
and this second thing, if there I don't see any questions over here, so it would be worth discussing on last 2 points where you have seen that there is no consensus. So about fibrinolytics, there was no consensus. About the VATS, there is no consensus. So basically, I think majority of the pediatric surgeon, wherever the facilities of VATS are available, would rather prefer VATS than using fibrinolytics. Thoracocentesis, again, you have said that there is no guideline about where to put. So that is generally an institutional protocol where to do the thoracocentesis. But as far as ICD drainage and simple thoracocentesis is concerned, it is a emergency life-threatening, life-saving procedure. So it should be available everywhere. And even pediatrician, even intensivist, pulmonologist, everyone should be trained about the procedure. That is one point I would like to make about the thoracocentesis. In our institution, where we are seeing huge number of patient thoracocentesis, before going ahead with any intervention like VATS or surgery, is mandatory, because significant number of tuberculosis patients we are seeing who mimic other bacterial effusions as well. So seeing thoracocentesis, seeing microscopy of fluid is a mandatory part of our work. We can have comments from the audience about it. And it is always safe to put the ICD in operation theater where all the resuscitation facilities are available. Putting ICD in ward becomes fairly risky. So, and most of the ICUs, they are well equipped with the all emergency life-saving procedures. So ICU can always be the setting, but ward can be difficult to manage if any complication occurs.
I think one aim of paper of Dr. Priyanka was there is a huge gap between the guidelines and the ground situation. So facilities available are different, whereas guidelines are different. So this paper nicely tries to bridge the gap regarding between guidelines and the ground situation. So whether you put chest tube every patient taking for chest tube to operation room may not be like theoretically or practically possible. So there is a question from audience also. Was duration of stay part of your survey or no?
No,
With
no.
the method of intervention.
We did not look at the duration of stay.
Okay.
I also have one comment. Standard treatment guidelines are given by IAPS also. Your references mentions IAP guidelines. Have you considered IAPS guidelines as well? Because this is published in JIAPS. I would like
So it came actually when after we finished, so we did not consider the IAPS guideline. It had
I
come
think
after we finished.
last 2020. So must be before your guidelines.
Okay,
So,
okay. We were not aware of it, sorry.
okay. Any other questions from the audience?
There's one question by Dr. Rahul Gupta. I think you can include that.
Yeah. Would fibrinolysis use interfere with future performing parts? You, in your survey, have you got any opinion about correlation of fibrinolysis with the VATS?
No, ma'am. We actually did not look at that perspective of it. We did not ask questions pertaining to that.
But I think overall the consensus or thinking in pediatric surgeons would be fibrinolysis, if it fails, it makes VATS more difficult. And the people who are doing VATS would agree that VATS is far more superior than fibrinolytics. Failure rates of VATS are very less, and this fail only when those patients are referred very late. And that is why I liked your idea of having survey about the considering the thinking of pediatrician and pediatric surgeon, because we always face a problem because these patients are referred fairly late in organized stage 3, where VATS become difficult. And the outcome of VATS is also become suboptimal. Later the UR and the outcomes would be the less optimal. So we all majority of the surgeons would prefer to go in stage 2 of empyema, where it is quick, it reduces the hospital stay, it improves the patient condition very quickly.
There is a recent publication in Indian Pediatrics. Dr. Priyanka might have gone through it. So, which is a debate whether surgical intervention or fibrinolytic therapy or VATS, what treatment. In that debate, the literature is also reviewed. So nowadays, fibrinolytic therapy and VAT are comparable. They are not like used in a sequential manner, that fibrinolytic first followed by VAT. Either in that stage you choose fibrinolytic therapy or you choose VATS. The disadvantage of VATS is requirement of anesthesia. And it is the results in various publications show they are comparable. So instead of being sequential treatment, now next step would be thoracotomy and proper decortication. So any other?
I'll give the last comment, what I feel overall. I
Yes.
think that has been already said, but just to re-emphasize, I think where the VETS facilities are available, people will go for VETS. And where the VETS facilities are not available, I think the fibrinolytic becomes the option. Because the number of days of stay and everything is much better with VETS as compared to fibrinolytics. That is what is our experience, and our intensivists and pediatrician will they tried fibrinolytics and then they compared and realized that VETS is much better. And today they don't try only fibrinolytics. They will straight away call surgeon and whatever. Some patient may need ICD, but majority of our patient will end up with thoracoscopy and debridement decortication. Yeah.
Sometimes,
Rasik,
Yeah.
just one. This nice paper, which includes pediatricians as well as pediatric surgeon and intensivist, I always feel that for the topics which are medico-surgical, we need to have more meetings. Last guideline I have seen by IAPS is by 2020, whereas IAPS 2022. So maybe it is high time that pediatrician and pediatric surgeon should come together and form the consensus statement, so that there are last two columns are not there, no consensus, no consensus. That
Yeah.
is going to give interaction, better quality of evidence-based guidelines as well.
So
And
Can I say something, Pradnya?
yes,
before you say,
Ah.
when they formed some of the guidelines and when they came out with the book, at least on empyema, they had involved me. This is for last almost now 17, 18 years. So I was one person from pediatric surgical side, and there were maybe another 10, 15 pediatrician for various guidelines. I was only part for empyema. Yeah, Ramesh Babu, please go ahead.
Yeah. See, we have published the standard treatment guidelines as a booklet, and it is available as a PDF for all conditions. But we are also in the process of doing individual detailed guidelines, like how IAP has done. IAPs will also do guidelines for each condition, like empyema and all. We have already allotted some topics. The empyema is also one of them. For some reason, it is getting delayed because we are collecting the references. We are in the process of writing it up, and then we will be submitting only to JIAPS when it is finalized. Because this is a referenced guideline, like how IAP guideline is done. So it's called a peer review guideline or evidence-based guidelines, and it is not a textbook, but it is based on the current evidence, and it will keep on changing, obviously. But I think each topic is going to come up soon, very soon.
Thank you. I think we can go to the next paper. Manoj.
But last comment, can I make, the survey has hardly less than 100 pediatric surgeon answering the survey. So we face same problem when we circulated the survey of on transplant. So it is sincere request to all the pediatric surgeon, they should take this survey seriously and answer all the questions in surveys, because these are the one who are going to give us evidence-based guidelines. So that was the take-home message for audience as well.
Sir, can I add
can go
one
to-
point? Sorry for interrupting.
Can
Can I last point?
We
Can I
can
add
move
one?
on to second. We will move on to the second presentation. Dr. Divya Prakash, please share your screen. Yeah.
Good evening, everyone. Today, my presentation is on unusual association of trichobazole. We came across one child, so it's not moving. We came across one 11 years old girl, and she came to us in our OPD with complaints of pain in abdomen of 3 years duration, and vomiting and decreased appetite was there of 1 year. Her mother noticed that she's having a habit of eating her nails and hair, and in spite of scolding her, she used to persistently do it when the parents were not there. She was having non-bilious vomiting, and the frequency increased for the last 2 weeks of 4 to 5 episodes per day. So she was evaluated many times outside, and where she was evaluated with ultrasound and a CT abdomen. CT abdomen was suggestive of the similar findings, that she had a bezoar of 30 centimeter in the stomach and extending into the duodenojejunal junction. On examination, there was definitely a large mass was there, extending from the left hypochondrium to the epigastrium, the right hypochondrium reaching up to the umbilicus. So on doing preliminary blood investigations, it is over here. These are the preliminary at the time of admission. She had a decreased albumin level, and phosphorus was also on a lower side, and electrolytes were normal. So we took her for the exploratory laparotomy. We did an anterior wall gastrotomy along the longitudinal axis, gastric axis, and a trichobezoar was removed in toto. And this is the full trichobezoar with its tail of 90 centimeter. Total length was 125 centimeter and her weight was 1 kg. In the post-operative period, on the till 4th day, she was absolutely fine. We started her orally. Next day, she started having all peripheral edema, facial edema, even her vulvar edema was also present. Abdominal drain output suddenly increased to almost 300 to 400 ml. It was serous only, and a decreased urine output to less than 1 ml per kg per hour. We sent the repeat investigations, which was definitely an electrolyte imbalance was there. Albumin was also low and a hypoglycemia. On the same day, she developed a generalized tonic-clonic seizures were there with uprolling of eyes. We shifted her to the PICU and enrolled the pediatric team as well. And we came to a diagnosis of refeed syndrome. Then the pediatricians definitely together we worked as a team. We kept her an NPO. They started the anti-epileptics, TPN was started, and electrolyte corrections were done. She was improving gradually, but on 12th POD, she started having abdominal distension and she was not passing stool and flatus. And the X-ray abdomen was showing the proximal dilated bowel was there and no gas was there in the pelvis. So we waited for we stepped up the antibiotics also. We have sent all the cultures, the abdominal drain culture, the blood culture. She had a central line also. We sent a central line culture, the urine culture, everything was showing no growth. Then we did an upper GI contrast study was done. For 48 hours, there was no contrast going into the large bowel. Even after 48 hours, we counseled the parents that we might have to go in again, and adhesions might be a reason for that. Early adhesive obstruction. But next day at 72 hours, she opened up the bowel and she passed a lot of stools and flatus. And then we gradually stepped up orally and TPN was tapered. And she stayed with us for 25 long days, and then we discharged her. After on first follow-up, we sent her to the psychiatric consultation also, and we started her on antipsychotics and antidepressants. Now, after 1 year of follow-up, she is absolutely fine. On a precautionary basis, her parents also shaved her all her scalp hair also, and now they have never noticed her having the similar habits. So on the discussion part will be that the trichobezoar definitely with Rapunzel syndrome is a rare condition, where Rapunzel word has come from the Greek fairy tale where the princess used to let down her hair from the tower and the prince used to come up, climb with the help of her hair and rescue her. And if it extends into the small intestine, that is a Rapunzel syndrome with a long tail. It is usually seen in the psychological disorders in young females, which are chronically malnourished, and only 1% of the cases with trichophagia, they develop trichobezoar. Then refeed syndrome definitely is a rare phenomenon. It's usually seen in any chronically malnourished patients who are started on feeds. This is a short cycle of pathophysiology of refeed syndrome. That in starvation, there is a catabolic state where there is a protein catabolism, glycogenolysis and gluconeogenesis is there, and all the electrolytes, proteins and fats are in a depleted state. When we refeed the child, the body goes into an anabolic state, and the glucose being the major source of energy, the insulin is secreted. Because of hyperglycemia, there'll be protein synthesis and glycogen synthesis, and all the glucose uptake, the electrolytes will be taken up, utilized. And since already the body is in the depleted state, it will go into all the electrolyte will be further depleted, and the body will start having fluid retention as well. The hallmark feature also in our case was hypophosphatemia, and it is a hallmark feature of refeed syndrome. The other sequelae is osmotic diuresis, dehydration, metabolic acidosis. It can further into a bad phase of ketoacidosis, increased carbon dioxide production, hypercapnia, and respiratory failure. Luckily, we didn't have that. Then, according to our PICU pediatricians, which is one of our co-authors, Dr. Amit Shukla sir is there. They have a PICU protocol of using a NICE guidelines, which states that patients who are chronically malnourished of more than 5 days, they start the TPN with less than 50% of their total energy requirement. So they started that, and the patient recovered very quickly, and they increased it gradually. They increase it every 2 to 3 days and increase orally as well. And when the orally comes up to 75%, they stop the TPN. In water soluble contrast, in our study has done miracles, because there are many studies also which have stated that the early adhesive obstructions in the early post-operative periods can be resolved with the water soluble contrast, just because they have high osmolarity, and it causes the water movements into the small bowel, and it increases the smooth muscle contractility, causing the hyperperistalsis, and it decreases the edema, causing the bowel movements to increase. So in conclusion, I would like to say that any patient who are chronically malnourished, refeed syndrome should be considered, should be kept in mind, and NICE guidelines, less than 50% of their energy requirement should be started with. And definitely there is a recurrence chances are there in these patients which have psychological disorders, and a psychiatric consultation and regular follow-up has to be considered for these patients. These are the references which we have considered. Thank you.
Thank you, Dr. Divya. That was very interesting case.
Thank you,
With
sir.
a rare finding which we don't usually see. In the first time, how did you start feeding the child?
So we started with ORS clear liquids. We started, and then we have a protocol that we gradually increase to liquid diet and then the soft diet. But in spite on the liquid diet itself, she started having the edema. The water retention was there.
So in spite of NICE guidelines being there and you following those guidelines, the patient developed refeeding syndrome.
No, sir. NICE guidelines was followed after that, when she developed all these features of refeed syndrome. We were not expecting to happen this, but later on it started happening. Then we shifted the seizures and everything. We shifted to the PICU, and then pediatrics. They suggested that this is the protocol what we follow for the refeed syndrome.
Yeah. So I think that is a nice learning point for everybody. Many times our patients are nil per oral for more than 5 days. So it is especially the patients who are nutritionally poor. It is nice to start. It will be beneficial to start gradual feeding rather than trying to accelerate. Because nowadays those ERA's protocol, etc., they recommend that you try to get patient off the bed as early as possible. So sometimes it may not be possible. So any questions? Yes.
Your investigation chart showed low phosphate levels and all. Was that pre-operatively?
Ma'am, one was pre-operatively. Definitely it was on a lower side, but post-operatively.
In normal circumstances, I don't think everyone does magnesium and phosphorus levels in every patient. Electrolytes, was there any specific?
Ma'am, in our hospital, we do renal function test. In this, the whole parameter is there, and the electrolytes, RFT, everything comes. We don't have to order it separately. They do everything in one investigation.
Auto analyzers.
Yes, sir.
And then these phosphorus levels were stabilized before surgery?
No, ma'am. Yes, ma'am.
So is that a reason why you saw refeeding syndrome?
Yes, ma'am, definitely, because we didn't expect, because matlab, during my experience and my seniors' experience, we have never seen such drastic like refeed syndrome in children. Like she's having full, even the vulvar edema was there, and decreased urine output, high seizures, and everything. That drastic conditions of refeed syndrome we have not seen.
So in your literature search, what were the measures to prevent this refeeding syndrome
Ma'am, in
besides guidelines?
Ma'am, in literature, we have not seen. Only hypoalbuminemia was there, which was treated with albumin supplementations in the literature. Especially in trichobazor cases, none of the literature has published the refeed syndrome. Yeah, they have encountered refeed syndrome.
Because most of the trichobazar cases are published by pediatric surgeons.
Even ma'am, in adults also, I searched about the literature. Nobody had such drastic refeed syndromes.
And which other conditions you see refeed syndrome besides this?
In any chronically malnourished patient, whichever the cause, can have refeed syndrome.
Okay.
So interesting paper. Dr. Manoj, can we go on to next, please?
Yes, sir, please.
Thank you, sir.
Third presentation, last for today, is Dr. Charu Sharma. Please share your screen. Dr. Charu?
Yes, sir. Yes, sir. Yes, sir. I am not able to share my screen.
Dr. Divya will have to unshare first.
So from where do I have to do it? So it's not unsharing, sir. I'll just.
Dr. Manoj, can you help?
Yeah, Vijay is a co-host. Vijay, can you? Hello. Vijay?
So I can't find.
Dr. Vijay?
Sir, I'm looking.
Can you unshare her screen? She is not able to do that.
Yes, sir.
Thank you, sir.
Dr. Charush, you please share your screen.
Yes, sir. My screen is visible.
Yeah, it's visible.
Good evening, everyone. First of all, I would like to thank the JIPS Abhigyan team for selecting this paper for presentation. I am Dr. Charu Sharma, Associate Professor in Pediatric Surgery Department at AIIMS Raipur. I shall be presenting delayed presentation of malrotation after infancy, a systematic review based on clinical presentations, associated anomalies, diagnosis, and management. Before I proceed to the introduction section, I shall just highlight the basis of this review. We all know that the typical presentation of malrotation is infancy. And also we know that the presentation after infancy is common, and that timely and appropriate diagnosis of malrotation is essential to avoid gangrene and subsequent gut loss and mobility. But what we don't know is because the incidence, there is limited available literature in the form of case reports and studies. There is no specific data on the incidence of malrotation after infancy. There is varied clinical presentations and no established management guidelines. With this review, we aim to coalesce these findings from various individual reports and studies. The incidence of malrotation is 1 in 6,000 live births. Historically, it was considered primarily a disease of infancy with infrequent occurrences past 1 year of life. And in neonates and infants, accurate clinical and radiological diagnosis is possible. Clinically, the neonate will present with bilious vomiting and signs of upper GI obstruction. On X-ray, there will be paucity of gas shadow beyond stomach, and USG and UGI contrast series will help in diagnosing. The USG will, with color Doppler, will show the typical Whirlpool sign, which is the swirling of mesentery around the axis, leading to SMA comes to lie on the right of SMV. However, in cases of delayed presentation, the true incidence remains undetermined because the presentation is variable. The patients may remain asymptomatic till adulthood or may not be diagnosed at all. They may be diagnosed incidentally, intraoperatively, or with symptoms of failure to thrive and vague abdominal pain. It is this class of patients which we need to diagnose because they are symptomatic also and they don't come to pediatric surgeons. Partial volvulus causes mesenteric venous and lymphatic obstruction, subsequently impairing nutrient absorption, malnutrition, and malabsorption-like syndromes. Diagnosis becomes more and more challenging as the age increases. The risk of gangrene remains the same because the anatomy of malrotation is the same. The base of mesentery is short and is susceptible to midgut volvulus with resulting significant morbidity and mortality. The chronic symptoms, postprandial bloating, intermittent cramping, and occasional vomiting are labeled as functional disorders and are never referred to a pediatric surgeon. So increased awareness of this condition as a differential diagnosis in children of all age group presenting with vague and chronic abdominal symptoms is necessary. Acute presentation with intestinal obstruction will be referred to a pediatric surgeon and managed. There is a controversy regarding the surgical management of asymptomatic or incidentally diagnosed patients. Some favor a conservative approach, citing reports suggesting a reduced risk of midgut volvulus in cases presenting beyond the neonatal period. They say that surgery may not be justified till the cause of abdominal pain can be linked to malrotation itself. On the contrary, there are reports of intraoperative findings of midgut volvulus even in adults, which confirms that the anatomical risk of midgut volvulus persists even after infancy. Hence, it's better to correct the anomaly in order to prevent any catastrophe. Moreover, the risk of volvulus ischemia and gangrene cannot be predicted based on the symptomatology. Proceeding to materials and method, this is my research question and primary objectives, which is the same as the title. I'm not going to repeat it again. This systematic review was conducted in accordance with the PRISMA guidelines, and all patients between 1 and 18 years of age with diagnosis of malrotation of midgut were included. All studies published in English and scientific journals were included. The search strategy and study selection, PubMed, Medline, Scopus, Google Scholar, and Web of Science were searched. These were our search basis. The search terms were midgut malrotation or midgut volvulus and children, not infants. Articles were retrieved which matched our search criteria and recorded. 2 independent reviewers extracted the data. The data were collected and entered in Microsoft Excel. The descriptions were summarized, simplified, and grouped for synthesis and comparison. The data extracted were study characteristics, patient demographics, clinical presentation and association, diagnostic methods, and treatment. This is the PRISMA flowchart showing that total of 714 records were identified. After removing the duplicate records and ineligible records, 457 records were screened. After removing ineligible records after manually screening, 160 reports were sought for retrieval. 5 were not retrieved as full text was not available. The reports were assessed. 155 reports were assessed for eligibility, out of which 53 were again excluded as they were not found to have all the criteria which we wanted, and hence 102 studies were selected. Out of these, 79 were individual reports and 23 were clinical studies, making a total of 803 patients in all. Some studies have reported patients with malrotation, including all age groups, from which we extracted the patients for our analysis based on their age of more than 1 year. Hence, some information was found lacking as to age, gender distribution, presenting symptoms, and management. We included all the data as available to the best of our knowledge and ability. Mean or median age cannot be calculated altogether, and there were 104 males and 61 females out of, as per the case reports and studies which have depicted that. Giving a short review of the included studies, the largest number of patients were seen in Malik et al. Study, and there were 219 patients. They concluded that they found that in 164, they presented with typical symptoms of bilious vomiting and pain abdomen. 55 had incidental diagnosis. 75 of these patients underwent emergency LATS procedure. 31 had volvulus and 7 required intestinal resection. There was 1 mortality. The conclusions of the studies by Amma et al. On 8 patients were that vague symptoms of overlapping abdominal pain and vomiting were the commonest symptoms, and these patients were operated based on clinical symptoms only, and malrotation was diagnosed intraoperatively. There was only 1 mortality. Uba et al. Presented that chronic symptoms and that mostly with increase in age, the patients present with chronic symptoms, and malrotation should be suspected in patients with recurrent symptoms of abdominal pain and vomiting, especially if associated with failure to thrive, and surgery should be done to relieve the symptoms. Penko et al. And Navi et al., I have clubbed their conclusions. They presented the consequences of late diagnosis of malrotation and insisted that late diagnosis of malrotation may lead to intestinal obstruction, gangrene, and prolonged morbidity. And diagnosis is delayed as the patients present with chronic symptoms. And contrast studies aid in diagnosis. In another study by Abu Elmat et al., he presented long-term outcomes of gut malrotation on 500 patients of malrotation over a period of 30 years. Out of these 500 patients, 101 patients presented after 1 year of age. Of this, 43 patients had gut loss, and 40 patients of the remaining 53 patients had variable symptoms of dysmotility. They also emphasized on surgical correction. Now, these 10 retrospective studies, I have clubbed their conclusions that the symptoms were more of chronic type in older children, mistaken for malabsorption-like symptoms, causing delay in diagnosis. In Ford et al., out of 102 patients, 11 were more than 1 year of age. They presented with acute symptoms like bilious vomiting, obstruction, and abdominal pain. The diagnostic tools were upper GI contrast study and barium enema. All patients underwent LATS procedure with appendicectomy. ICE et al. Compared 101 patients with malrotation, dividing them into 3 groups based on their age of presentation. 9 patients were more than 1 year of age and presented with bilious vomiting and abdominal pain. All underwent LATS procedure. Again, these 3-4 studies, they conclude the same thing, that chronic symptoms are more common in older children. Less than 2 years of age, typical symptoms of bilious vomiting and acute pain abdomen is presented, but more than 2 years of age, chronic recurrent symptoms become more, and symptoms become non-specific. LATS procedure may or may not be able to satisfy all the non-specific symptoms. Now, analyzing the numbers, the clinical presentation can be acute, chronic, recurrent, recurring, acute on chronic, and admission for other complaints. The most common were recurring acute on chronic, seen in 301 patients. The presenting symptoms were overlapping, and most common were abdominal pain and vomiting, seen in 285 and 275 patients respectively. Associated anomalies, intussusception, that is VAW syndrome, was seen in 11 patients, followed by pancreatic anomaly seen in 10 patients and acute appendicitis seen in 9 patients. UGI contrast series was the most commonly used diagnostic technique seen in 250 patients, followed by CECT seen in 94 patients and abdominal USG with color Doppler seen in 54 patients. Open LATS procedure was done in 723 patients. Laparoscopic LATS procedure was done in 71 patients. 7 patients were not operated for malrotation, and one case report didn't mention whether surgical intervention was done or not. And intraoperative midgut volvulus was present in 134 patients, not present in 70. Rest all didn't mention. Now the discussion. There can be 3 kinds of presentation: acute, chronic, or incidental diagnosis. Acute presentation is like sudden onset of abdominal pain and bilious vomiting seen in 560 patients. And those who presented in emergency are evaluated and diagnosed. And they may present as sepsis and shock due to gangrene of volvule as a result of volvulus. Chronic presentation is with vague abdominal pain with or without vomiting. Intermittent and recurrent episodes are there, and these episodes increase with increase in age. Acute on chronic presentation is also seen in 301 patients, and these are mostly due to intermittent volvulus with history of multiple consultations with pediatrician. Gastroenteritis and malabsorption is the diagnosis which is made, and hence there is a delay in referral to pediatric surgeons. The incidental diagnosis is usually seen during workup for acute abdominal pain, such as associated with War syndrome, pancreatic anomaly, or acute appendicitis. A word about War syndrome. War syndrome is an association of malrotation and intussusception. The available literature reports this association to be as high as 40%. It is limited to scattered case reports and small series only. Presence of mobile ascending colon in cases of malrotation predisposes for the prolapse of the terminal ileum and proximal colon into the non-fixed distal colon. We observed 11 patients of War syndrome in our review. Diagnosis is a plain X-ray showing dilated stomach and paucity of gas shadow beyond is suggestive. The diagnosis, UGI contrast series, ultrasound abdomen with color Doppler, CECT is a newer tool for diagnosis, and mostly CECT picks up malrotation as incidental diagnosis only, mostly. Exploration for other causes is also intraoperative finding. Management is by surgical. LATS procedure during the years has been recently laparoscopic LATS procedure is being done. Rates of gangrene are requiring resection are more in chronic patients. Management of short gut syndrome, this requires. And doing appendicectomy for acute appendicitis and leaving malrotation uncorrected as it was asymptomatic is seen in 7 patients in our VA. And one report did not mention about surgery for malrotation. Before proceeding to conclusion, the study by Abu Elmad et al., 500 patients over 30 years, they found that 101 patients were more than 1 year of age, 43 patients had gut loss, and 40 patients of the remaining 53 patients had variable symptoms of dysmotility. Risk of gut loss is there, and hence the importance of surgical correction. In an evidence-based analysis by Graziano et al., they concluded that there is lack of evidence to support screening of asymptomatic patients for malrotation. On incidental diagnosis, operating on younger patients may be considered while observing older patients. Atypical malrotation with a broad-based mesentery and malposition of duodenum can be observed. Laparoscopy is a useful tool for confirming the diagnosis and correction as well. Observation may also be considered with extensive education of family and caregivers and close clinical follow-up. To conclude, clinical presentation can be variable. Acute is more common in less than 2 years of age. As age increases, the kids usually present with more chronic symptoms. Diagnosis may be incidental while operating or investigating for other complaints or anomalies. Diagnosis was previously made by UGI contrast series, but recently USG with color Doppler and CECT scan are being used to aid in diagnosis. Management is operative. The paradigm is shifting towards the minimally invasive approaches, and recently laparoscopic LATS procedure is being adopted. Patients who present beyond 2 years of age and with more vague symptoms may not benefit for LATS procedure. Even watchful waiting may be preferred. The timely and appropriate diagnosis of malrotation is essential to avoid gangrene and subsequent gut loss and morbidity. Larger population-based studies are needed for establishing guidelines for management of asymptomatic or incidentally diagnosed malrotation. Thank you.
Thank you, Dr. Charu, for your presentation. That's extensive review of late presentation of malnutrition. So what one learns from this review is that one should not forget patients presenting with atypical symptoms which are not fitting into any diagnosis. Malnutrition can be a possibility. So with that, are there any questions from the audience? So Dr. Pradanya?
There is one comment actually. Extensive study, however, systematic reviews and meta-analysis ideally should focus on more niche topics with fewer studies to draw the conclusion from, which I partly agreed, because in your conclusion, once you said ki surgery is mandatory, and one you said ki beyond 2 years in a symptomatic patient, large procedure may not benefit. So even at the end of such an extensive review, we are still left with the question mark whether surgery is mandatory or not. So that answer I would expect from you. And last you said कि larger study is required. This I thought is already a huge study. Why do you think you need even larger study? You have covered almost 800 patients, 102 studies. So what more you want?
Ma'am, actually, most of these studies had patients included, neonates and infants also. We want specific more than 1 year of age with delayed presentation. What is happening to them? And then we want some trials or comparative studies to do whether they are operated and what is the outcome of operation or non of the clinical, just observing them. Such studies are not available. Means only this many studies which are very heterogeneous. Some studies give clinical symptoms, some studies give what they have done. Some studies didn't even mention whether gangrene or volvulus was present or not. It was from 802 patients, I only got 700 conclusion, and 134 patient had volvulus. But what about the others? Did they have volvulus? Did they have So it's very difficult to.
So instead of larger study, maybe prospective study comparing newborns and comparing patients who are presenting later than 1 year may be better idea.
Because delayed presentations are fairly uncommon. We are seeing hardly 1 or 2 patients in a year. So conducting such studies would be extremely difficult on these patients.
Yeah, so the suggestion which I think earlier also we had was having countrywide database of some of the conditions. Then we can
Yes.
come to some better conclusion than, otherwise.
Yes, sir.
Yeah.
But one thing is certain, like what Pradnya said, that there cannot be two conclusions. I mean, one is at one side we say that in an older child, if not operated, the chances of gangrene are higher. And the second, in the same slide, that we can observe, which doesn't go together. I think most of them should be operated for prevention of complication like gangrene.
Actually, these conclusions were drawn from the studies only.
Yeah, but I think finally you should conclude from all the studies, what is your conclusion?
No, we should operate. We should operate.
That-
Even
that
recently
is-
diagnosed, it should be operated.
If
So any other
Yeah.
comments or questions from the panel itself?
Or we can carry on with the agenda. Manoj?
Yes, sir. So before we conclude, that was very thought-provoking session. Before we conclude, we would like to invite, we have our Honorable President IAPS with us, Dr. Ramesh Babu. Would like to request his insightful comments on this session and his comments for this. Please, Dr. Ramesh Babu, sir.
Before we call our president. Can I say something?
Yeah, please.
Yes, please.
Dr. Rasik, actually, guidelines are there, but what we realize that not everyone is following the guidelines. Like if it is case report, care guidelines, Prisma and all those, and not all students are aware, neither all reviewers are aware. So I would sincerely suggest that JIPS should start some workshops on training postgraduates and young pediatric surgeon on doing how to make a more scientific and acceptable publication, and simultaneously there should be more training of the reviewers. I think this has been in your mind since long time, and we should materialize that.
Yeah, so we
Right.
wanted to start the session last month, but somehow the dates we not last month, but in October, actually last month. Then we said October, but October also there are a lot of talks from IAPS Con. So I'm not sure whether it will be possible or not, but let's see. But it is the agenda of having some kind of workshop for publication. So let's hope that it starts. So alternate month will be JIAPS Abhigyan, and alternate month will be some kind of assistance for publication and research. That's the plan. I think Ramesh Babu has left. He is not seen. So we can carry on. Vijay, you can carry on.
So, regarding the vote of thanks, I would like to thank our moderators, respected Dr. J.K. Mahajan sir and Madam Dr. Pradnya Bendre madam, and our speakers, Dr. Priyanka Medi, Dr. Divya Prakash, and Dr. Charu Sharma, for thought-provoking discussions on the 3 different varied topics. I will also like to thank President sir for sparing time with us, and our editor sir, and our coordinator sir, Dr. Manoj Joshi sir, will be doing the Abhigyan 4 shortly, and will be publicizing it in different groups. Thank you all for sparing time. And I think thank you. We can close the session now.
Thank you.